Dr. Marta, can you join us here? So we have 10 minutes for questions, if anyone have any questions with the 4 presentation.
Hi. Hello? Oh, I'll shout. We often see our dialysis patients who have atrial fibrillation. The management of atrial fibrillation on dialysis is really controversial, but we hate warfarin because of its effects on matrix-GLA protein in particular. What dose of NOACs should we use if we're going to use a NOAC, or how can we stop using warfarin?
That's a very good question, and this question is in each Congress, I think. There is no clear answer. I cannot. New anticoagulants are not indicated in hemodialysis, so we don't have any study, any research approaching this subject. So I always give warfarin. I'm sorry, I don't give new anticoagulants to hemodialysis patients. Yeah. Yeah, I know it's difficult, but anything you do is not very scientific. It's not based on anything, because in the pivotal trials, these kind of patients are not there. So we need a big study, randomized study.
So I mean, I agree with you, but in the general clinical practice, there has been, with patients' experience and with doctors' experience, there has been a use of low dose of pexaban in dialysis patients. Whether this is right or wrong, there is no evidence, but you're in the realm of no evidence. So you're free to use clinical judgment in that position and then manage the patient accordingly. But again, as Dr. Marta said, no evidence. So. She's asking why aspirin is not indicated anymore in patients with low CHA2DS score. If you don't have an indication for anticoagulation, why not give aspirin?
Because aspirin doesn't avoid embolic stroke. This has been well proven. Yeah. Yeah, in these cases you have to either not give anything in CHA2DS, I mean CHA2DS 0 or 1 in women, nothing or anticoagulation. But aspirin increases the risk of bleeding without preventing the risk of stroke. What about? Sorry, COVID? Yeah. Yeah. You can use new anticoagulants during even if the patient has COVID. But is this the question? I don't know if this is the question. Yeah. Yeah, the answer is the same. Yeah, the answer is the same. COVID is a very recent infection, so we still need more evidence. But the answer is the same. Aspirin doesn't prevent stroke in this kind of patients.
We have the question regarding also such patients like hemodialysis or already renal impairment, and he was on warfarin, and he came in hospital with the INR like 6 and no any picture of bleeding. What is with AF, and do you think, and you have any update about for correction of this? Like say LINR between 9 and 6 will give the to correct the coagulopathy, prothrombin complex, or something like this with such patient in AF, and he has some risk to correction of this coagulopathy. I mean, for warfarin.
I'll just repeat your question for everybody. So you're
Yeah.
basically talking about a dialysis patient who comes in with supratherapeutic INR on
Yes.
warfarin, and how to manage such a situation.
Any update about the correction of this? I mean,
So you will collect the INR according to your standard of care. So giving FFP if the patient is hemodynamically stable. We generally try to avoid vitamin K antagonist because we try to avoid giving vitamin K is because you're planning to anticoagulate this patient later, and having an INR of 6 or 7 can be reversed without, especially if the patient does not have active bleeding. So you can reverse it with other agents and then resume anticoagulation. This patient would be a perfect candidate for device therapy. So this, if you see this patient should be referred for device therapy for left atrial appendage exclusion. Because this patient will continue to have labile INR because he's on dialysis. This patient will be receiving IV heparin during dialysis, so he's going to have a higher risk of bleeding rather than a normal patient with warfarin. So for these patients particularly, you have to refer them for devices. I think we have Professor Joseph Collett also with us online. Yeah, we have a question here. Go ahead.
My question is on the CHA2DS2-VASc score. When it mentions like say, for female 1 point and then you add another point to be eligible for anticoagulation, what's the difference? Why we remove that point and make for both male and female 2 points? What's the benefit of adding a risk 1 point for a female and then adding 1 to the score to be eligible?
Because being a female per se doesn't increase the risk of stroke alone, if you consider the sex alone. But if you have other risk factors like hypertension or diabetes and you are a female, you have more risk than male. That's why.
Yeah, but would it matter if we put it as a point and then add 1, or we just calculate the other factors?
If you are female and you have CHA2DS2-VASc risk of only 1 because you are a female, then it's equivalent to have a CHA2DS2-VASc of 0. So having being a female doesn't increase. If you are only female without other risk factors, doesn't increase the risk of stroke. It's by adding other things, hypertension or cardiac heart failure, that you have more at risk. You are more at risk than men. Okay.
So I have a question for Professor Joseph. It's Steve Holt here from Saha Kidney Care. I thought the elegant studies on the myocytes using the seahorse to show that iron deficient myocardial cells produce less ATP. We know that infusion of iron in some patients causes hypophosphatemia. Is that because the myocytes take up more phosphate from the circulation? Is it just depletion from the circulating pool?
Well, first of all, thanks very much for the invitation, for being here with you. Not broadcasting from Catalonia, but it's like I was there in Dubai. And also, I want to make the most of saying hello to Marta. We've been working together a long time. She's one of the best EP cardiologists I ever met, so it's great to be here all together. So regarding your questions, hypophosphatemia is one of the problems that we've seen using particularly ferric carboxymaltose. You're right. The prevalence of this problem is less than 10%. I would say actually hypophosphatemia with symptoms is less than 100%. And it doesn't seem to be the fact that actually there would be, I would say, a link between phosphate and this abnormal iron handling. At least from the experiments we did, there seemed to be a very casual relationship with exposition to neurohormonal activation. I didn't show specific information on animal models. We also developed an animal model that we actually confirmed the results within the cardiomyocytes. Hypophosphatemia in recent studies have been seen that it's not common problem. So it wouldn't be, I would say, the main reason to explain these abnormalities at the cardiomyocyte level. And at least from the Aspirin study that's been recently published, hypophosphatemia used in the acute setting seems to be no problem at all in patients with heart failure.
So we'll take this last question because I think we're running late.
Good morning, and thank you so much for the nice speeches. My question meant to be for Dr. Shihab, but I think he already left. So, 59 years old, morbidly obese, occasional smoker, presented to my clinic last year with uncontrolled diabetes, hypertension, a newly discovered dyslipidemia, and metabolic syndrome. I've started him on all the medications, and he was optimally controlled. 1 year later, he developed acute coronary syndrome. So I think this candidate is the perfect, he's a perfect candidate for bariatric surgery. When would we recommend this patient to safely proceed for the bariatric surgery following the acute coronary syndrome?
So it depends what kind of acute coronary syndrome he has. So which artery was involved, what kind of stent was placed. Generally, we prefer not to send a patient for a major surgery within the first year after an MI, but there could be exceptions. So the broad answer would be a year after his myocardial infarction. He can go for bariatric surgery. It's a very important clinical problem. If he has gone to bariatric surgery before, he probably wouldn't have the MI. It's important to know, was he really controlled in his lipids or not? Sometimes we just completely controlled, okay? Because it's always important to remember that we have targets. It's not just the therapy, but we do have targets and to reach in terms of lipid lowering.